Melanoma. Melanoma is a malignant tumor arising from melanocytes. Melanoma as incidence is rare, but its incidence in the last few years is markedly increasing. Why? Due to the defect in the ozone layer. As any skin malignancy usually occur in male above 40 in fair skin. Melanoma never recorded and never seen before puberty. What is the predisposing factor for melanoma? As all previous skin malignancies, basal cell carcinoma and squamous cell carcinoma, fair skin, albinism, and we said before that dark skin is protective against skin malignancy, and xeroderma pigmentosa, prolonged exposure of patient with fair skin or albinism to ultraviolet rays, or repeated injury of nevi, especially nevi in the shaving area, and precancerous lesion including junctional, compound, and giant pigmented nevi. What is pathology of melanoma? This is the xeroderma pigmentosa, leading to, in this patient, to multiple melanoma, multiple malignant tumors, melanoma. This tumor arises from the melanocytes, either de novo or on top of previous nevus. Pathologically, there are many types according to the level of the melanoma. The commonest melanoma is superficial spreading type. This is about 65% of cases. Superficial spreading type. This type is actually some sort of carcinoma in situ. The malignant melanocytes spread in the epidermis only, above the basement membrane, and it will form flat or slightly elevated pigmented lesion with irregular edge. And all these malignant cells present only in the epidermis. The most dangerous type is nodular type. Nodular type is about 25% of cases. The malignant melanocytes spread in the dermis. Spread in the dermis. And this is the most dangerous and carrying the poor prognosis, leading to formation of a raised nodule, which may later on ulcerate. Lentigo maligna. Lentigo maligna, as we said before, in the lentigo and benign melanocytic lesion, this usually occur in elderly, in the face and in the hand, arm, foot, and the malignant cells limited to the basal layer, spread in the basal layer only, and may undergo regression. And this lentigo maligna is not dangerous. And usually we leave the patient alone, and the tumor may regress and spontaneously disappear. there is acral lentiginous lesion. Acral means peripheral. Peripheral in the hand, foot, or in the nails, like this malignant melanoma in the nail bed of the big toe, or in the foot, or in the hand. And this highly malignant tumor with very poor prognosis. Acral means peripheral. A melanotic melanoma is the most malignant melanoma. A melanotic melanoma is rare. It is a melanoma without any pigmentation, like this. No brown or black color of melanin. And this usually occur in very dangerous area, in the eye, in the meninges, or in the mucocutaneous junction. Mucocutaneous junction, like the lip or the anal canal. And this amelanotic melanoma, which is melanoma without formation of melanin, is highly malignant. Microscopically, melanoma highly malignant epithelioid or spindle-shaped cells with or without formation of melanin. But in the lab, we know that these cells are melanocytes. How? By a biological reaction or biochemical reaction called DOPA reaction. DOPA positive reaction means this cells is capable to form melanin, and the only cells which can form melanin is melanocytes. Clark's level of invasion. Clark's level of invasion to suggest the prognosis or staging of the tumor. Clark's level of invasion divide melanoma according to the level of invasion. We all know that there is epidermis and the basement membrane of the epidermis. Then there is the dermis. The dermis is divided into papillary layer and reticular layer. And below the dermis there is a subcutaneous fat. Level 1, which is carcinoma in situ. The malignant cells limited to the epidermis only, above the basement membrane. And this carcinoma in situ sure has the best prognosis. And level 2. Level 2 is spread of malignant cells to this layer, which is the papillary layer of the dermis. Level 3 is spread of malignant cells to the junctional zone between the papillary and the reticular layer. Level 4. Level 4 is spread to the reticular layer. Level 5 is spread to the subcutaneous fat and the underlying structure. Therefore, level 1 above the basement membrane. 2 is spread to the papillary layer. 3 junctional zone between papillary and reticular. 3 is spread to reticular. 5 is spread to a subcutaneous fat or underlying structure, and sure this is the poorest prognosis. Also, there is a Breslow classification. Breslow classification classify melanoma according to the thickness of the melanoma. If melanoma, the thickness of the melanoma is less than 1 millimeter, this is called level 1. If the thickness of the melanoma from 1 to 2 millimeter, this is called level 2. If the thickness from 2 to 4 millimeters, this is called level 3. More than 4 millimeter is level 4. To remember Breslow classification, level 1 is 1, less than 1 millimeter. Level 2 is 2, from 2 to 1 millimeter. Level 4, more than 4 millimeter. And sure, level 3, between 2 and 4, from 2 to 4 millimeter. Level 1, less than 1. Level 2, from 1 to 2. Level 4, more than 4 millimeter. And level 3, between 2 and 4 millimeter in thickness. What is the complications of melanoma? As usual, spread mainly to a surrounding structure. Direct spread to a surrounding structure. Lymphatic spread by embolization and permeation. By embolization, emboli of malignant cells passing in the lymphatics. Permeation by the malignant cells creeps on the surface of the lymph vessels. This leads to very important two clinical features of melanoma, which is, this is a primary tumor, and you may find malignant deposits in the lymph vessels around the primary tumor. These are called satellite nodules. And transit nodule. This is a malignant melanoma in the popliteal fossa, and this is the patella. Malignant melanoma in the popliteal fossa, and what is this? Malignant deposits in the lymph vessels passing towards the draining lymph nodes, which is the inguinal lymph node. What is this? These malignant deposits along the lymph vessels from the primary to the draining lymph nodes are called transit nodules. Therefore, spread along the lymph vessels is called the transit nodules, or presence of malignant cells and malignant deposits around the primary is called satellite nodules. Blood spread as usual to 2L and 2B, lung, liver, bone, brain, and finally ulceration, hemorrhage, anemia, cachexia. What is the clinical picture of malignant melanoma? Melanoma, if occur in previous nevus, there is nevus present stationary for many years, rapidly increase in size, rapidly becomes itchy, painful, hard or indurated, ulcerated, bleeds, increasing pigmentation, or surrounded by a hollow pigmented area. Surrounded by a hollow pigmented area like this. Hollow pigmented area around. All this suggests malignant transformation of the nevus. If de novo, any pigmented skin lesion in adult, rapidly growing, ulcerating, painful, itchy, indurated, should be considered as melanoma until proved otherwise. In addition, there may be manifestations of malignancy like satellite nodules, transit nodules, fixed to a surround structure, enlargement of the draining lymph nodes, and distal metastases. Investigations, as usual, dermoscopy and Doppler ultrasound. Why? Any melanoma with thickness more than 1 millimeter has a blood supply detected by Doppler. Therefore, if we detect pigmented lesion and has blood supply detected by Doppler, this should be considered as melanoma and should be removed and examined pathologically. Excision biopsy for a small lesion. We perform incision in the same line of the incision of the definitive surgery, and remove the pigmented lesion with 3 mm safety margin, and the specimen is examined either by frozen section or better by paraffin section. Incision biopsy for large lesion, especially in the face, to avoid disfigurement. What is the differential diagnosis of melanoma? Any pigmented skin lesion like benign pigmented nevi and mole, pigmented granuloma, pigmented basal cell carcinoma, pigmented squamous cell carcinoma, and hemangioma. That is to say, differential diagnosis of melanoma is other skin malignancies, in addition to other nevi, pigmented granuloma, and hemangioma. What is the treatment? As usual, operable or inoperable, with all features as we will know previously. Treatment of the operable case can be divided in treatment of the primary and treatment of the secondary. Treatment of the primary according to thickness. Breslow classification is the most important in the prognosis. If the thickness of the tumor is less than 1 millimeter, remove the lesion with 1 centimeter safety margin. If the thickness is from 1 to 4 millimeter thickness, we remove the lesion with 2 centimeter safety margin. If the thickness of the tumor more than 4 millimeter, we remove the lesion with 3 centimeter safety margin. Therefore, to remember this, according to Breslow classification, less than 1 millimeter, which is level 1, remove with 1 cm safety margin. From 1 to 4, which indicate level 2 and 3, Breslow, remove with 2 centimeters. 1, 2. If more than 4 centimeters, remove 3 centimeters. Therefore, remove safety margin 1 to 3 centimeters according to the thickness. Regional lymph nodes. Clinically, if negative lymph nodes. If no regional lymph node enlargement, sentinel node biopsy. We all know what sentinel node. Sentinel node biopsy and pathological examination for the biopsy. If negative, sentinel node. And clinically, no regional lymph node enlargement, therefore just follow up of the patient to detect any lymph node enlargement. But if sentinel lymph node positive or clinically palpable lymph node, radical block dissection of the regional lymph node, removal of the draining lymph nodes, which is called radical block dissection. Post-operative chemotherapy, radiotherapy, immunotherapy, target therapy, but in malignant melanoma, radiotherapy is in general not recommended. Therefore, chemotherapy, immunotherapy, and target therapy. In operable cases, palliative chemotherapy, palliative immunotherapy, and we all know that immunotherapy stimulates the immune system against cancer. What is target therapy? Target therapy will give the patient a drug, and this drug is target the genetic defect which cause the malignant tumor. Palliative resection of the primary or lymph nodes may be needed. This is melanoma. Thank you for good listening and good luck.